Welcome, everyone. My name is Dr. Aimee Ferraro. I'm a senior core faculty member in Walden's public health programs. I'm also an epidemiologist who has been conducting research on COVID-19 throughout Latin America, primarily in Peru. I will be serving as the moderator this evening, and joining me today are three spectacular women who are also part of the Walden community, and they're extremely passionate about making a difference during this pandemic. Dr. Cynthia Hickman is a published author, speaker, proactive caregiver advocate, and nurse educator. She's also a Walden University alum, social change fellow, and grant recipient. Dr. Charlotte Hughes Huntley is the CEO and principal consultant at DrCHHuntley LLC, creator of the Public Health Consulting and Entrepreneurship Expo, and host of the Public Health Epidemiology Conversations podcast. She is also an adjunct professor of public health and a Walden alum. Dr. KaRae Powers-Carey is a registered nurse, clinical mental health counselor, and core faculty in Walden's School of Counseling. She is also serving as the medical operations section chief for the Maryland Department of Health and has a plethora of experience getting COVID-19 vaccines in arms through her work with mass vaccination sites in North Carolina. As you can tell, we have a highly qualified panel of experts for our conversation this evening. And to get started, we'd like to give the audience a bit of context before we jump into our conversations and stories. Kayla, could you go to the next slide, please? So to begin, I think it's important to define what we mean by BIPOC. It's a term that will help us understand the population of interest we have for our conversation this evening. BIPOC stands for Black, Indigenous, and People of Color. Black refers to people of African and Caribbean ancestry. Indigenous refers to Native American and Indigenous people of the Americas, while people of color is an umbrella term for non-white persons who often face discrimination. This includes Asians, Middle Easterns, Indians, Pacific Islanders, and Hispanics and Latinos. This is a term that acknowledges not all people of color have the same experiences or deal with the same types of injustice, but it also helps foster a greater inclusion of people who have faced racism and mistreatment because of the color of their skin and their culture. Next slide, please. There's no doubt that this pandemic has devastated nearly the entire world. However, COVID-19 has had a disproportionate impact on BIPOC communities. Earlier in the year, the CDC reported that Black Americans had hospitalization and death rates up to 9 times higher than white Americans. American Indians and Alaska Natives had 9 times as many cases and 4 times as many deaths as white Americans, while Latinx and Hispanic Americans had 3 times as many deaths as their white counterparts. Now, some of these disparities can be explained by differences in comorbid conditions, as well as existing inequities in healthcare access, things like structural bias. But as the pandemic continues, the differential rates of COVID-19 infection, hospitalization, and death are also being attributed to vaccine hesitancy in BIPOC communities. So as of this week, federal data from the CDC shows that 78% of the adult population in the United States has received at least one COVID-19 vaccine. However, we know vaccine coverage is uneven across the country. The percent of white people who have received a vaccine dose is about 54%. While for Black people, it's only 46%, and for Hispanics, it's 51%. This means that BIPOC communities are still at increased risk for COVID-19 infection, hospitalization, and death, especially as the Delta variant continues to spread. Next slide, please.
So some of the historical experiences for people of BIPOC communities can be traced back to the abuses that have been perpetrated in those communities. For example, in 1932, the infamous Tuskegee experiment, also called the Tuskegee study of untreated syphilis in the Negro male, commenced. There were 600 Black men in the study. 399 of those had syphilis, while 201 were without the disease. They were all told that they were being treated for bad blood, and in reciprocity for their participation, they will receive free medical exams, free meals, and free burial insurance, which in the 30s was a very big deal. In 1943, penicillin became available, but it was not offered to the men who were infected with syphilis. In 1972, an ad hoc advisory panel stopped the study and ruled the study ethically unjustified. And in 1973, the Department of Health and Human Services instructed to provide all necessary medical care to the survivors. In 2004, the last airman died. Moving to the next point, the blood samples from the Havasupai tribe. This is a situation where the members of the Havasupai tribe had voluntarily given consent on a broad consent form for which many of them did not have a high school diploma and couldn't read it, and English was their second language. They consented to the samples to be taken of their blood because the faculty and students at Arizona State University were going to try to find a genetic link for diabetes amongst the tribe. However, they did not find that genetic link, but instead used the blood samples and published papers on inbreeding, alcoholism, and theories which conflicted with the tribe's core beliefs. Going into racial bias in the healthcare system, we can look to the case of Henrietta Lacks, who went to Johns Hopkins complaining of vaginal bleeding, and she was diagnosed with a malignant tumor on her cervix. Samples of her cells from a biopsy were sent to a local tissue lab run by a doctor who was a prominent cancer and virus researcher. The cells were sent without Mrs. Lacks's knowledge. While most tissue samples that were sent to this doctor died soon after receipt, Mrs. Lacks's cells doubled every 20 to 24 hours. Her cells are termed the HeLa cells from the first two letters of her first and last name, and they continue to impact the world beyond her death at the age of 31 in 1951, as many of the HeLa cells are used to do medical research. So many questions asked by the BIPOC community when it comes to working with the medical community is, how can I be sure that this is going to actually help me and be a positive research outcome and not harm themselves or their group? There is a lack of awareness of clinical trials and a lack of access for medical care in those communities. And there's a lack of trials in areas where there are African Americans. There is no awareness of disease or illness trials and how it can impact their community in many ways. Next slide, please.
We also know from the literature that structural racism and implicit bias have an impact on vaccine uptake in BIPOC communities. So a study by Quinn and colleagues found that experiences of discrimination in the healthcare setting decreased trust, increased perceived risk of side effects, and reduced uptake of the influenza vaccine. This was before the pandemic. Systemic racism and provider bias are also associated with poorer patient-provider communications and interactions, lower quality of care, and negative health outcomes. Next slide, please.
So there is a concern with inequitable distribution of vaccine doses and a failure to place clinics in areas that are accessible to BIPOC communities. There's a reliance on web-based registration systems in order to even obtain the vaccine, and many people are not technologically savvy. There are restrictions with the hours that the clinics operate, and people have to work. There are also limited childcare options for adults to receive their vaccine, and a lack of transportation in order to get to vaccine sites. For example, if you were to decide that you wanted to get a vaccine and were going to go to a drive-through max vaccination site, you would need a car. You would need a license to drive that car. If you didn't have that and you decided to take an Uber or a Lyft, you would wait in long lines, which would then be cost prohibitive for you to receive the vaccine. Also, many of the mass vaccination sites are understandably in large areas which are not centralized near BIPOC communities or people who have been disproportionately singled out and don't have access to the vaccine. Next slide, please.
So there's many reasons why people are not getting vaccinated with the COVID-19 vaccine. We can't assume that vaccine hesitancy means vaccine refusal. And it's also important to note that skepticism in BIPOC communities can be protective. Perhaps asking questions and taking time to make a decision helps them avoid another Tuskegee incident. So as health practitioners, it is our responsibility to ensure institutions are being trustworthy, transparent, and engaged with all communities. And to do this, we have to focus on relationship building. That includes active listening to other stories, like we will do tonight, bidirectional communication, mutual learning, and ongoing discussion. This isn't an issue that's going to be figured out and through one conversation and it's over and done. This is going to be a long-term issue that keeps coming back up. So with that, yes.
If I may add that we also need to integrate learning about BIPOC communities in our medical healthcare training systems.
Good point. That's another ongoing long-term solution we need to start thinking about. This isn't something that we can fix right away, but perhaps over time it'll get better, right? So at this point, I think we can open up our questions to the panelists. We could go to the next slide, please. And yes, to the first statement we have, and I'd like to open this to Dr. Hickman first. If you could please share a story about an experience you had during the COVID-19 pandemic that illustrates the challenges of vaccine hesitancy and how you overcame it.
Wonderful, wonderful question. And I will start off by saying that I have an empty chair in our home, in our family. I have a niece that I lost to COVID-19 in June. I'll start the story by saying that I was on a tour. I stopped by Toledo, Ohio to talk to my niece. Now, surprisingly enough, my niece was a registered nurse. My niece did have underlying issues, however. I talked to her. Her name was KaRae K. King. I talked to KaRae about the importance of getting vaccinated. KaRae had a long list of why she did not want to get vaccinated, and most of them were aligned with her health conditions. Now, I thought it was very puzzling. It puzzled me only because KaRae was a registered nurse. She had worked in the hospital. She understood what the pandemic was doing. She also had read about how many people had died prior to her becoming infected. KaRae was infected around the second week of April. I was back home in Texas. My sister called to inform me that KaRae was in the hospital. I immediately dropped to my knees because the conversation that I had with KaRae over 2.5 hours did not convince her to get vaccinated. I felt like a failure as a nurse, a practitioner, because it seems like everything that I said, she did not hear it. And she was fearful. And then she became hesitant. And so I kept thinking about fear and then hesitant. Subsequently, she was hospitalized. The last conversation I had with KaRae was on April the 25th. She was intubated at that time. Prior to that, they were trying to let her breathe on her own, and she did not do well. Prior to her intubation, we also found out that KaRae's son, 18-year-old Aaron, who was the valedictorian of his class, his mother was supposed to get out of the hospital to go celebrate with him. That did not happen. So when KaRae was intubated, prior to the intubation, she texted her mother and she said, please make sure Aaron gets vaccinated. The same time when she made that comment, we found out that Aaron also had COVID. Aaron was 18 years old. So Aaron did fairly well as KaRae continued to struggle with COVID. KaRae died on June the 3rd, 2021, after a 7-week battle of COVID. It was a terrible death. It was a horrible experience. But KaRae realized before she died the struggles that she had, and she did not want her son to experience that. So we did get Aaron vaccinated. Aaron contracted COVID again. He had the Johnson & Johnson. He contracted COVID a second time. So he went through that. He was a little sicker that time. He pulled through, and we finally got him vaccinated again. The concern that I had about KaRae's story was the fact that she was educated and she was fearful. She did have the concept of nobody's going to take care of me. She made a comment about her insurance running out. If she went to the hospital and stayed for a long time, her insurance would run out, and then she wouldn't get the type of care that someone who had lots of insurance. And to watch her and listen to the dynamics of a person who understood COVID and did not get vaccinated was very heartbreaking. So the experience now that I share is because now KaRae's life has turned into our plight to help others. It's painful at times, but I say to people, you really don't want that empty chair at your table, because the last thing that my sister was able to get from KaRae was a recording of her heartbeat before they took her off the ventilator. So I say to you, even with people with education, sometimes the fear is real. And so I did not approach her as, you will do this. I tried many times to ask her why and how, or what can I help you understand? Or how can I help you explain it? Who do I need to take you to? Maybe you don't want to listen to me, listen to someone else. So the hesitancy has a lot to do from experience that I've seen is fear. I'll briefly mention quickly, my sister-in-law just lost her mother last week to COVID. Her mother was at home with her brother and girlfriend, who both were not vaccinated, but she was. And they refused to get vaccinated, but they were a caregiver to the mother that was 70 years old. The mother died with COVID. The son is still fighting for his life now with COVID because of that experience. Again, it was the hesitancy of what we know in the past. Tuskegee came up. Hospitals don't treat Black people the way they treat white people. And I don't want to go there and they give me something and they will not give, and I get the same thing. So I can just say that let's operate with the art and science of healthcare and medicine and not the noise.
Yeah, thank you very much, Dr. Hickman. First of all, I'm very sorry for the loss in your family. I think that many of us have losses like this and we all have to deal with the empty chair. I really respect how you are using this as an impetus for getting out to educate people so that they don't have to feel the same way. We really honor your story and the work that you've been doing, and I'm so thankful that you're here with us this evening to share this.
Thanks so much.
Yes. Dr. Huntley, I'd like you, if you could answer the same question or share your story. I know you have a similar story that maybe getting at this idea of fear.
Yeah, thank you for this question, and thank you, Dr. Hickman, for being so vulnerable and for sharing and to use this as an opportunity to educate, which I know that you're very passionate about. I found it interesting that you mentioned fear, because that's exactly what I was going to bring up. For me, I'll step back a little bit. At the early part of the pandemic, as an epidemiologist, I felt overwhelmed and bombarded from everyone coming at me in every different direction. I have a strong background in infectious disease. And then as an epidemiologist, I mean, I was overwhelmed with questions and from family, from everywhere, clients, everyone. And I had to kind of pick and choose my lane. So I put boundaries up. I had to decide where was I going to put, really throw myself into this. I was frustrated, like a lot of professionals in public health, with the constant changes. Some days we would win in the communication aspect, and some days we would lose. And so it's as a professional, it's very frustrating. When it came to vaccine, the early conversations about the vaccine, I really perked up and paid a lot of attention, because I do, as an epidemiologist, I spent a lot of my time working in pharmaceutical industry and was just very naturally interested in what was happening and what was going on. So I had my own questions, and I decided this is where I was going to dive in and learn as much as I could. I knew that when they began to roll out, the elderly members in my family were going to be the first people eligible, and they were also going to be the ones with the most questions and probably the most resistance. So I'm going to add this in here because my family dynamic is a little different. I have a blended family. So my biological family, my mother's, all my family that I'm connected to biologically are in this elderly group are Black, and then my in-laws are white, so they don't even fit part of the BIPOC community. But what I noticed is fear was consistent. So they were all dealing with fear around, their hesitancy and their questions and their anxiety around the vaccine were all driven by fear. So for my in-laws, their fear surfaced, and it really stemmed from their very conservative political views, were the source driving the fear. With my mother, her aunt, her sister and brother, so my aunt and uncle, that was clearly a result of their personal, upfront, close relationship and experiences with racism. My mother is 88, so my mother has walked, lived, experienced a lot of the things that we read and talk about as if they were so long ago. That's real life for her. So I knew where a lot of their fear was coming from, and they had a lot of questions. So I made myself available to it started out with the elderly members of my family. So I will tell you that it was very, very difficult to understand that no matter how much I tried to talk to certain people, it could fall on deaf ears. And I could really feel for Dr. Hickman and how she talked to her, her niece, and she kept having the conversation and she kept going there. And it was just, to just not make that impact is frustrating. So what I had to really keep doing was looking at all of the things that were frustrating me at the time and think, okay, this is an opportunity to learn. Like, our people, our family members, the people we care about are having these questions and this anxiety for a reason. They're fearful, they're confused. This is an opportunity to not fix it, but learn from it. So why is there fear? Like Dr. Hickman was saying, I kept wondering and questioning why. And for the members that, if I would have the conversation on a day and the walls were so high, I would just have to decide to let it go and revisit it another time. So I really approached them, especially the elderly. I found that one of the best things you can do for them and engaging with them is to give them the respect of their story. So I asked them about their experiences in the past with vaccines, or in the past with, diseases and problems that we've had. And I listened to them and I let them talk. And then that reciprocate, they would listen to me. So I was able to help them. I was able to help answer their questions. And they're all in different states. We're talking about Florida, South Carolina, Mississippi, Maryland. So at the early rollout, every state had its own set of rules. So I'm researching all the different details of these different states and answering questions for them, and really helping to give them the factual information without pushing. It was a delicate dance. But my aunt, my mom, my uncle were they were among the first to receive the vaccine. As soon as it was available, I was able to take my mother to get hers, my aunt and uncle. I walked them through it. They got it quickly. My in-laws made the decision. It was a little bit longer before they had some hiccups just trying to navigate the steps, but they did get the vaccine, and they were all very appreciative. And that whole experience, my family watched that. So the other members of my family that had their own issues, it laid the foundation for us to have more conversations. So I continue to have the conversations with, even my husband had a lot of issues and questions and a lot of hesitancy. So I used that same approach, and was able to work with, the immediate members of my family. And even at this point, there's of our immediate, my husband, myself, our children, our parents, and probably our aunt and uncle. There's one family member that is still struggling to get their questions answered. But I'm very thankful for that. It has been a way that I've been able to just communicate with them and just keep working with them, and to be able to just kind of try to understand, even if I don't have to agree, but just try to understand. That helped me to kind of deal with it.
Yeah, Charlotte, I think what stands out in your stories is that you took the time to figure out each person's individual fears and experiences first before helping them either or overcome those fears or just respond to questions that they have. I mean, as this is all rolling out, and to go back to what Dr. Hickman said, just because somebody's educated doesn't mean that they also understood everything that's happening during this pandemic. We have these new mRNA vaccines, so you might hear something unique to that versus a person who's living in another state where it's just the Johnson & Johnson vaccine. And so maybe those same questions won't arise there. Political views coming into it. So what are their sources of information? And so it may be these conspiracy theories you have to answer for one person, and yet another is going into the past and talking about Tuskegee and why we now have, informed consent and a whole new set of ethical considerations that didn't exist back then. And so we hope that those kinds of issues don't arise in 2020 and 2021. I do think that for myself as well, that's what I've had to keep in mind is you need to have a personal conversation so that you can address each one of those fears and issues individually. Thank you for your story. Dr. KaRae, now it's your turn. I know you've been working with larger populations on this. So you probably have lots of stories. Do you have any that stand out related to this issue?
Thank you. And thank you, Dr. Hickman, for sharing that story about your niece, and to you, Dr. Huntley, for talking about education and how important it is. And I'll springboard from Dr. Huntley's points about education. In working with missions in the state of Maryland to get the citizens vaccinated, there is a person that stands out to me. And it took over a month of her coming and just popping in, asking questions of the clinicians there, myself included. Her concern was she was a young person, she was healthy, no underlying conditions. Did she really need to get the vaccine? But her grandmother was elderly, and she told her granddaughter, who was the person who was coming to our clinic weekly, that she couldn't come over to the house and be near her without being vaccinated. The grandmother was concerned for her own health as well as for the health of her granddaughter. And so her granddaughter had many questions, is this real? Is this a conspiracy? Is it a hoax? Will it happen to me? I'm young, I'm healthy. But her main drive was really wanting to be with her grandmother. It had been over a year since she'd been in the same space with her grandmother. Her grandmother was not tech savvy, so there was not FaceTime. There were just kind of conversations on the cell phone through a window. And that was the most interaction that she had had. And it was very heartbreaking. As someone who's lost my grandmother, I can only imagine not being able to hold your grandmother, hug her and everything. And those were the conversations that we had. Conversations that really centered on what the vaccine might provide for her as far as peace of mind for herself, for her grandmother, and safety. And so that's where we focused. And eventually she did get the vaccine. But again, this is after many conversations, after much education, after her really coming to her own decision about what she wanted and what would be best for her and her family. And that's one of the things that Dr. Huntley was hitting on as well, that we have to be respectful of where people are and meet them where they are with respect to these conversations. And like Dr. Hickman was saying, not dictate to them what to do or force them into a decision, but really respecting the boundary that it's up to them what they want to do with their own health, and the decision about taking or not taking the vaccine is a very, very personal one.
Yeah, these are excellent points. Do you find that in the work that you've been doing as well, that is it helpful to have a conversation about sort of the risk benefit analysis? I feel like along with fears comes with, I feel there's risks for X, Y, and Z, whether it's we don't know what it does to our reproductive system. I'm afraid that it's going to actually give me COVID. It's going to change my DNA. You hear all these kinds of risks. And do you go through those step by step and then counteract with a benefit, or is it a spectrum? Can you talk a little bit more about these conversations you might have?
Sure. I can only speak to what scientific information exists today. So I don't dismiss what their concerns are for the future. Of course, with medications and other things, as time goes on, there have been things that have been found that may be untoward for the future, but I always try to focus them on the here and now. I give them the information that I have and that I know, and backed up with science and research. And we also have a myriad of clinicians available. They're nurses, they're doctors, they're public health experts that are there to get a wide lens for the individual questions that may come our way with regard to the vaccines.
Wonderful. Yeah, thank you for that additional information.
The other
With that,
comment that the other
please.
comment that happened is, when they started having so much hesitancy and fear regarding the vaccine, I asked the question to those who I had an opportunity to speak with, and I said to them, can you please tell me how you were feeling when we were inoculating our children to go to school? And I asked the question of how many of you that you can honestly tell me prior to that experience that you went to the encyclopedia, you found scientists to ask the questions about MMRs, for example. And of course, no one could answer that question because back then, if the pediatrician said it was time for our children to get their inoculations, we picked up Johnny, we rolled up his pant leg, and we let him get a shot in one thigh, a shot in the other thigh, and off we went with Tylenol. And so, those are the things that we did to allow our children to go to school. And so a vaccine is a vaccine. A vaccine saves lives. At the same time, we do recognize nothing's 100%. And that's one of the conversations I would mention. The art and science of nursing or healthcare, that's why it is an art and a science, because we're ever changing. We're still trying to understand it, but we're relying on our scientists, as Dr. KaRae said, we're relying on the science to make it reliable so that people can understand it. And I do let people know all the time, this is not a political situation. I know many try to make it political, but when people lose their lives, that's not political. That's the reality of what we're dealing with right now. So we have to look at what has happened in the past, although we know there's bad things have happened, but there's more good in what has occurred in the art and science of medicine.
Very, very good point. Dr. Huntley, before moving on, do you have anything you wanted to add? I don't want to just move on without making sure everyone is okay.
Yeah, those are just agree with those points, taking them one issue at a time.
Perfect. Kayla, can you move forward to our next question to the panelists? Thank you. So this is open to anyone who wants to speak up, no specific order. Maybe if you want to raise your hand and I'll call you out first or something. What do you think we could be doing better to address vaccine hesitancy in BIPOC communities in particular?
I think one of the main things that we can do is take the vaccine to them. Barriers to access is so huge in these communities, and relating to them when they have questions, not judging, but being empathic and understanding that there's a lack of knowledge. And many of us have been there before, whether it's in higher education or school, where we didn't know information. We asked for information and we received it without judgment, very willingly sharing of information. And I think that's what needs to happen. And that's what's critical, is that we need to take the vaccine to where they are in their own communities and provide the education to them, especially when asked.
Can you talk a little bit more about specifically what you've been doing? Because I know you have some examples of how you've been doing that.
Certainly. So in some of the missions that we've been doing in the state of Maryland, we've taken the vaccine actually to the communities. We've set up in front of social services offices, for example. We emphasize that the vaccine is free of charge. You do not have to have health insurance. No appointment is needed. These things are very vital because in the initial stages of the rollouts, then that's what you heard. You got to register online, you got to make an appointment, and then you have to get there. And then if you're late, then you wouldn't be able to get the vaccine. And you have the observation period of 15 minutes. We explain that as well, or 30 minutes, depending on the status of your health. And we explain that. And I think going out to the communities and where they are speaks volumes. It lets them know that we're there to serve that community. We care about them. And that's an important message to relay as well. As a nurse, especially, I always want to relay caring about people and about their health. And so going to them, answering questions, meeting them where they are at their educational level and understanding level is also very important. I wouldn't want to speak over the head of someone and they're still not understanding me. That's not helping them and that's not educating them. But I need to find out where they are and meet them where they are and provide the information that they need specific to the questions that they are asking, and not just inundating them with science and facts and figures.
Yeah. One at a time, one question at a time you have to address, right? Yeah,
Exactly.
Excellent. Dr. Huntley?
Yeah, I wanted to add to that because I remember at the very beginning of we were beginning to roll out, that one of the things that was so complicated for my mother does not, she's not on the internet, she does not have a smartphone, and we were required to register online and wait for the appointment. She doesn't have an email address or anything, so I had to go through a lot of hoops to create a profile for her and an email address, and do all of that for her in order to get her set up. Now, fortunately, they went away with that rather quickly, but I guess to the point, one of the things that we could do to make it better is just to keep it simple. We do not have to overcomplicate this. There's already enough anxiety and fear and questions. If we keep making the process so complicated, that just adds another barrier. So I think that as much as we can simplify this, whether it's access to the vaccine, bringing it to them. I love that idea of being right in the community and really having people on hand to just being ready to talk to them, not really making it hard for them to go look for someone to answer their question, but just being right there in front of them. And it just makes it easier for them to feel more comfortable and open up. And I think that that's one of the biggest things we can do.
Yeah, great point. Thank you for that. Dr. Hickman, do you have anything to add to this question?
I did want to mention one of the things I think was another issue for the hesitancy and fear of the different kinds of vaccines. When they were starting to make the vaccines from the various companies, everyone got really, I guess, again, anxious and fearful again, because which one do I use? Which one do I do? And I know many people said, well, I only want to get stuck one time. So they ended up going for Johnson & Johnson. And so somewhere along the line, that seemed to be problematic for some people. But I think the fact that there were so many discussions around whose was the best, was it Johnson, was it Pfizer, was it, Moderna? And so you had this swirling of confusion on even which one do I get? And then again, so the fact that there are 3 of them, and now I just heard that the children's is coming out, and so it's a third of the normal dose. So is that a third of the normal dose? Is that for the child who's 5, that's 10 pounds, or the child who's 25 pounds? And so you're going to have that issue again. So as Dr. Huntley and Dr. KaRae both said, it really boils down to meeting them where they are and having an understanding on their level to try to get, individuals inoculated, vaccinated. We just have to meet them where they are.
You bring up an interesting point too, that's going to come again now that the booster shots are coming out. And I do think we have a little bit of armor or ammunition on our side, and that the CDC and FDA have decided it doesn't matter which one of the boosters you get. If you got J&J in the first time, it's okay if you want to get Moderna or Pfizer now. And so that should eliminate some of the confusion over which one is appropriate. But as we're seeing at the pharmacy level, sometimes the pharmacists aren't aware of the dosages and there's children getting too much. This is going to be a continual process to make sure that there's going to be new questions coming up all the time, I think, and we don't know when we're going to get out of this. I'm also starting to field questions about how does it mix with the flu vaccine? Do I do them at the same time, 1 week apart? So over time, I feel like as a public health practitioner, my job has been this entire pandemic to constantly read the new science coming out so that I can answer the new questions and be one step ahead. So that would be my advice to other public health practitioners at this point. You have to be very well read. Okay. Kayla, can we go to the third question, please? So to finish off, can we talk about some tips and tools you can share that will help shift the focus from vaccine hesitancy to vaccine confidence? I don't know if you found any resources or just personal tips you might have to others who are trying to have conversations with their family members, colleagues, whoever, the BIPOC community, to encourage them to get vaccinated.
In the Black community, it's very difficult to have a conversation with someone who doesn't understand. So I think for me, the tips that I would just have is to let them tell us what they might think would help. Because maybe in turning it around to that degree, that maybe we can better answer the questions that they're asking us. because we can give them what we know is helpful. Read this pamphlet. We're assuming that people can read and understand it. We're assuming we're giving them information. It might be, 8th grade level, and they might read it 4th grade level. So that's not going to help. So I think probably asking them first, and then using that as a strategy to define what it is they're asking.
That's a great tip, because maybe they don't need any more reading, and maybe they just want to talk too. Talk to somebody that they trust, who they think is an expert. That's a great tip. Dr. Huntley?
I love that. I like to add to that. I think that I absolutely love that. Let them tell us, and instead of us making assumptions, or no one wants to be told what to do. And I think for myself, if I'm having some confusion around something, or if I'm having trouble making a decision, the last thing I want is someone like in my face breathing over me, trying to tell me what I need to do. But making it really comfortable for them to open up and start talking about it is really important. And I think that building trust. So when we're talking about BIPOC community, we've got plenty of folks who are members of all of these communities, Black, Indigenous, people of color, that are educated and strong and credible, that can show up in their own communities, because that will go a long way to where there's already a trust. And if they are hearing and receiving and communicating with people that look like them and understand where they're coming from, then that is going to open up the door so much wider to us getting to the root of whatever the real hesitancy, the anxiety, the questions, the fear, whatever that really is. So I think really pulling the people of color to serve in their own communities will go a long way in helping.
That's great advice. See, you just got me thinking, because you've got your podcast and you use that as a method to communicate to a wide audience. Do you feel like there's certain forms of communication that fit best for these kinds of conversations or education of BIPOC communities?
Oh, that's a great question too. I don't think there's one over the other, because people who like podcasts listen to podcasts, but they may not watch videos all the time, but people who love videos are not going to maybe watch a podcast. So I think if we just show up, so as the people of color who are going to be the influence, or the professionals, the public health professionals, the trained professionals that are going into the community to help, just use whatever avenue works for you and just show up there. Like, for example, with my podcast, one of the reasons, we were talking about this a little earlier, one of the reasons I'm very visible all the time on like social media, I want people to know I'm a Black woman that's, not in her 20s, but a little bit older. And I want them to see who I am, see the face behind the voice, so that they can, and that matters. I get, even with students that I teach, I hear it all the time. I get messages, oh, it's so, I'm so inspired just to see a woman doing this, leading and doing this, or a woman of color, a Black woman, an older woman, just being visible and present, no matter what the platform is or whatever route is, I think is probably just the way to go. Just be very present.
Yeah. And as a health educator, in the School of Public Health, we're starting to pay more attention to educating our students about communication in general, public health communication. I'm not sure all of us took courses on that. Like when I did my master's degree, it wasn't part of my coursework. It's something I've had to learn over time. And to use Instagram versus podcasts versus flyers versus campaigns. Down in Peru, I used more traditionally in a shanty town, for example. They do meetings of people coming together because they don't all have phones. They don't all have they definitely don't have internet. So it was still a formal face-to-face getting in touch with a person. And so I think we all need to keep that in mind. It's very contextual. Each community is very different. And so I'll even go back to Peru. This isn't a United States thing, but each shantytown community I was in had a different way of meeting. Some was in a church. Someone was in almost like the godmother of the community's house. She was the person that had been there the longest and knew everybody, and they'd meet there. Some was in the social services organization. So we need to be aware of what services these BIPOC communities are actually using, and so that we can get access and use those gatekeepers in there, the people that they trust already, and then help disseminate that information that way as well.
Yeah, I agree with you, Dr. Ferraro, regarding getting into communities where they are, because some of the missions that we do go literally where they are, to a McDonald's parking lot, set up and outside of a grocery store, vital things that people are going to use, the post office, places that they're going to go and where they're going to be found. But with regard to question number 3, the tips and tools to share to help shift the focus, a lot of times people are very tense when they come and ask these questions. The fear just grips them. And so I try to diffuse that with a little bit of humor. And I'll say to them, well, there are startling statistics about people who are having complications and dying from COVID, but have you seen the same for people who've been vaccinated? And then they laugh and they're like, well, no, but not yet. And so then it can springboard into a conversation about their hesitancy and what their concerns are. Usually it is about some future ailment that may come that we don't know about today, that they've heard about online or in social media, or just conjured up in their own minds. But having that open space for them and holding that space to allow them to go from hesitancy to confidence, I think is most critical, as Dr. Hickman and Huntley had already hinted on as well earlier, that holding that space, allowing people to have agency over themselves is very critical, and remaining judgment free for whatever decision that they make for their life. Because if you come out with the judgment, then you're preventing them from having future conversations that may take them from hesitancy to confidence.
Well said. I like use of the word of agency here too. It's something we've been touching on, and in so many health issues, agency is super important for successful outcomes. So keeping that in mind with COVID-19 vaccination is, of course, the most important thing right now. Thank you so much for all of your stories. I think at this point we can move forward. I do want to keep mindful of the time. We have about 10 minutes left, and I think there's some questions in the chat. Kayla or Julie, are there any that we should be answering, or do we have time to go on with our last few slides?
Sure, there is a question in the chat that Will posed. Is it possible or likely to move through the pandemic if very few children wind up getting vaccinated in the USA?
Great question. Anybody want to offer an answer, or I can speak up if nobody else has an idea?
I think my fear is the children are subject to what the adults do. And although we think that not vaccinating them or them not being vaccinated would be okay, my concern is they're going into schools and environments where people who may or may not be vaccinated. So I think to me, it begins to be a revolving door if we don't somehow get herd immunity. Is that what they're calling it, herd immunity? Can we get herd immunity with our children? I wonder, I haven't really heard that term with the children, but are they in the umbrella of herd community? I think to save our children, protect our children, I think we need to get them at a level where they're protected. And if they're in homes where their parents aren't protected, we may have some issues somewhere down the line with that. So I just would hope that people would get the tools and understanding to protect the children who can't protect themselves. I think that's our responsibility. But again, that it goes back to the education that is really necessary to move that needle forward.
Yeah. You brought up the magic term herd immunity, which I think is important to discuss here, that we don't really know what the magic number for herd immunity is in this case. We know from past pandemics that it could be about 70% for something, for a respiratory infection. But for something like measles, it's actually more like 95%. And you can still have outbreaks like we've seen recently in Southern California. They come back because imported cases, and we have not enough. We go below that 95% vaccination rate. So I think health practitioners, Dr. Fauci set cutoffs like 70% and maybe even more. But I'll tell you, in all honesty, based on my experience in Peru, that there were 90% of people infected in certain communities in Peru, and they got reinfected when a new variant came out. So we have no idea whether the children all getting vaccinated is going to stop all of this. That's why really I think the faster we can get as many people vaccinated as possible is the faster, or the better chance we have of reducing the number of variants that can come out. And that's the real reason. I don't think this is ever going to go away entirely. And that's what most public health practitioners are talking about now. There will probably be some low-lying level of, hopefully low-lying level of transmission. And over time, it will be an acceptable number of deaths and hospitalizations. And so hopefully we can open back up again. But certainly, like Dr. Hickman just mentioned, that children are still vulnerable. So giving them the opportunity to be part of the vaccinated population is one step in the right direction. Dr. KaRae, did you want to add something?
I did. I wanted to just have people think about children, where they go, how many adults they interact with, school. So they have the teachers, the staff, the faculty. They go to daycare where they have the daycare providers and any other visitors that the daycare provider may have in the home. They go to playgrounds and play with other children, and then they're near the parents of those children. And I just bring up those points to say that children are around a lot of adults, whether if they're unvaccinated, can bring things back. So just like they do from schools, you know, sometimes kids they catch a cold and then the whole family catches a cold from being exposed to that child. So I just wanted to just put that out there to think about children, even as vectors that can carry this around, and that at some point during this pandemic had come up about, no, children are fine, they're safe, but then no, we're finding that children are being infected themselves. So I just wanted to give that for food for thought for people to think about when it comes to vaccinating children.
Yeah, thanks so much. My intuition is that if we've seen vaccine hesitancy now, it's going to be twice as much over the next 3 or 4 weeks as these vaccines for children get approved.
There's some people excited and can't wait for their children to get it. And then there's others that are still going to dig in. Like Dr. Hickman mentioned, the parents really are the decision makers in this. It's the children have to follow suit. So if we're going to shift the conversation, you got to start with the parent. Although I'll be honest, sometimes I've been quite impressed with how children have responded to this. I just had a conversation with somebody about mask use and how we're still not good at keeping masks above our nose. You know, you still see people with letting it drop, but I watch children correct their masks all the time. And so they're almost more vigilant than we are. So maybe it still is an opportunity to start at that age to get them thinking about it. Maybe they can go back home and start questioning their parents, and these kinds of, they're not necessarily ultimatums, but you know, push points that get parents thinking about it. And then maybe that's enough for the parent to go and ask their family physician whether it's appropriate. And so, yeah, I think you're exactly right. It'll be interesting to see what happens in the next coming months. We are already, like I mentioned, 78%. I think it's still only in the it's around 60% of the population has 2 vaccines. And so maybe it could get us up to 65%, 68. The 5 to 11-year-olds isn't that large of the population to bump us up over the 70s still. So we still have a lot of work to do.
Yeah, I just was thinking about that, and the time that I worked in virology, what I really took away from those years is that viruses will do whatever they want to do. So as long as they have a body to infect, they will continue to spread and mutate, and we will have all unlimited number of variants. So I think you know, that right there keeps me you know, wanting to protect the children. Like Dr. Hickman said, they can't, you know, they don't think about all these things. And as a virologist of a few years, I just am not comfortable with trying to guess at what that number is. You know, it's not, so you know, is it going to be 90? Is it going to be 7? Let's just get the vaccine to as many people as can safely, you know, be vaccinated. So I also like your point about getting the children kind of involved. When I walk my neighborhood every morning, there's a 3rd grader that I pass by waiting for the bus, and he always gives me the update. He stands there with his mask and he's waiting for the bus. He gives me the update on what class has been sent home because someone was exposed, and how they're, who's doing what they should or shouldn't be doing on the bus with their mask. He's like the mask police. But I think that it just points that there's a lot of opportunity to really start teaching children at a very young age.
Yeah, I agree. Thank you for everyone's points. Do we have any other questions, or we've got about 3 minutes left till the end of the hour?
I have a few questions. Yep, just a couple of minutes left, but a question in the chat, how do we incentivize or reward the gatekeepers when they open doors like this? Many people assume that these gatekeepers don't want, deserve, or need anything when they help.
Very good question. Dr. KaRae, have you been working with gatekeepers during your missions in Maryland?
Well, the overarching attitude here is to have the shots in arms, make it available. That messaging that I was speaking about earlier about making that messaging clear, that is free, no appointment needed. You can get it right now. And like Dr. Huntley was saying, keeping it simple. Here's what you have to do. You get to hang out with us for 15 minutes to 30 minutes, depending on what's happening. At a great opportunity. And then we give them their vaccination card. We encourage them to take a picture of it if they have a smartphone, so they always have it with them. And sometimes conversations come up about, oh, well, I'll need this for a flight, or I'll need it to keep my job. And those become very serious conversations. So there isn't a stoppage of offering the vaccine to anyone who wants it. So the attitude with the state is that we want shots in arms. We want to make it available. We want to make it easy and simple for people to be able to get it.
And say for like when you work at a social services organization, do you give anything to that organization to allow you to be there for the day?
So it's important to note that we don't work with the organization. We get permission, which, it comes from the state, to just be like in the parking lot. So as people are coming in or out. So if we do at a grocery store, for example, we're in the parking lot now. In the colder months, then they're welcoming us to come inside, of course, and set up shop there. But it's not in cooperation or in a need to get their cooperation. It's a state mandate from the governor. And so that's what gives us the authority to go in and to do these things. We are definitely respectful of the businesses that we set up near, but it's really our audience is for the people. So as they're walking in and out, as they're going about their, going to get their groceries, they're like, oh, there's the COVID shop place. I'll get mine now. And it works out great. No appointment, it's free. And they really like that the different clinicians are there to answer questions for them.
Yeah, I can say from my work in Peru for working with gatekeepers that I like you just mentioned, it's maybe helping them understand that I will be doing the work, not you. I just need the access. I need you to help me have access. And I have given, and I'll when I have a grant, for example, and I have some extra funding, I will give compensation to a gatekeeper, usually ask them what they want. If it's, some organizations want, I'll think back to, let's say during the pandemic, they need masks. Or maybe they don't, maybe they'd like soap instead, and so I would ask your gatekeeper, what is it they really need, instead of just assuming, almost like the same as when we're going into conversation with individuals about this. Don't assume that you understand what their issues are. The gatekeepers may have some things coming up. Maybe they want flyers made by you, so you got to get creative and reach out to them, I think is a good idea. Wonderful. Okay. So I think we're at time, are we not? And so does anybody have any closing comments they'd like to make? Anything you feel like you wish you could have said and these questions didn't bring it up? This has been an excellent conversation so far.
Yes, Dr. Ferraro, Dr. Hickman, Dr. Huntley, and Dr. KaRae. Again, I had worked in the medical arena prior to my military enlistment. And also after my military enlistment, I started work as a civilian at Womack Army Medical Center for Bragg, North Carolina. During which I had used myself as an example to convince to transition from hesitancy to confidence. I was briefing anthrax. And I use myself, the soldiers trusted me more than the people from the health community, because I shared my experience. I was part of the conspiracy theory. Then until I started working in the hospital, understanding the virus, understanding the anthrax vaccines more and the literature, then you back your presentation with, or your briefing with your experience. And I believe if the healthcare givers can also, doctors, nurses, those that work in medical arena, can go to the community churches and get their shots in the front of the crowd, the audience, then maybe that will go a long way in convincing, removing that layer of suspicion.
Good idea. That's wonderful.
Yes.
Yeah, thank you, Valentin, for your position on that. That is a good idea. That's getting at that trust and transparency, isn't it? Yeah.
Yes.
Excellent. Okay, well, thank you everyone for your contribution to this discussion. I hope this has given you a few solutions for going forward and having these critical conversations with family members, colleagues, other members of the BIPOC community. We will be sharing a recording of this presentation and these slides on the Center for Social Change website. It's been posted in the chat. We also had some extra slides at the end of this that we didn't get to. Lays out some steps you can take for having a persuasive conversation, as well as other resources. If you are a person that needs to communicate in BIPOC communities, there are tons of toolkits and websites out there, pre-made infographics that you can share. So we've provided some links that you can use. And feel free to reach out to us if you have any questions. We would love to continue this conversation. We'd love to hear your stories. So please be in touch. Yeah. Thank you all for a nice conversation. Have a good night.